Good afternoon, ladies and gentlemen. I stand here on behalf of my institute in an effort to share with you as to how we were able to establish a public-private partnership in the country of India with a specific model that was implemented in the state of Gujarat. Prior to that, we ought to know some things about this institute which took up its journey into this public health initiative activities. We started with a humble beginning in 1989 through a small clinic that we had in a village which was around 100 kilometers away from Mumbai. When we started this clinic, we got patients who came far and wide, and the amount of time and money that they spent in coming to meet us, they insisted that we better start mobile dispensaries in these villages. So first in 1993, we started with a small jeep which went door to door in those villages. And few years down the line, we created a very large mobile vehicle, which in itself has a consulting room, a laboratory, as well as provisions to take care of patients. Looking at this added advantage that the people got in about the health services that they had, the demand started cropping up for an institutional setup to have these patients admitted, because the nearest place that they could admit themselves was 100 kilometers. So in 2000, we established a hospital, which is in Palghar, which is again 100 kilometers, but it is right in the heart of the place where people need it. When we created this hospital in 2000, people started asking for more. So we conceded to demands again. And in 2002, we constructed another hospital right in the heart of their villages itself. That's the hospital that we were just discussing in the last session. What we actually tried to establish was a model that we were trying to take to treat the patients primarily at his doorsteps by taking the mobile at his house. If you are unable to take care of the patient at his doorstep, you bring him to a center which can take care of its primary health needs. So we created a primary health center. If you are unable to take care of those needs which the primary health center is unable to take care of, you need to have a secondary referral center. So we created a secondary referral center. Mind you, we were not competing with the government to replicate or duplicate the system that is in existence as on date. But we were trying to make an effort to share what homeopathy can do with a similar chain that is already well established with the government machinery. But this time we were very focused that we will cater only to the mother and child segment. And that is the baggage of experience that we carried when we moved on in our life. That was a service model. This is a service operationalizing model. The service operationalizing model begins at the grassroots. A village lady who is 7th passed is trained into primary health services, first aids, homeopathy in its primary requirements. This lady, one village is a model, is monitored by a person who is called as multi-purpose worker, who monitors around 5 to 7 of these community health volunteers. These two people in turn are modulated and monitored by a medical social worker. We have coined this term in our organization, normally you know as master in social work. We have coined the term as medical social work. This medical social worker is primarily a person who is trained in social work. He is a master in social work, but he is oriented into concepts of homeopathy and application of it at the community level. They collectively end the triangle of the pyramid when a homeopathic physician gets involved when it actually comes to delivery of medicines to the patient who is sick. This model, ladies and gentlemen, first initiated in Mumbai, in the state of Maharashtra, in a taluka called Vikramgarh, which consists of 3 PHCs. Primary health center is a primary unit of healthcare system in India. It normally covers one taluka. One taluka is a place which has a population ranging from 35,000 to 1.5 lakhs to maybe 2 lakhs as well. Depending on the geographic needs, the PHCs increase. Therefore, we see a large number of PHCs that we cater in the state of Gujarat, in the taluka of Karjan, where we are catering to 1,79,000 people. The latest entry that we made around few years back was in the state of Karnataka in the taluka of Rawalgullu, which has 5 PHCs. This is a population of around 31,000. Looking at this background experience that we carried on, this novel idea of a tripartite public-private partnership got into effect. Government of India, Ministry of Health, Department of Ayush came up with a novel idea of national campaign of Healthy Mother, Happy Child. And incidentally, we were a group which was active in this field for a large number of years. Having gathered a huge basket of experience in operationalizing these services, we became the most eligible candidate for this marriage. When this sharing of experiences was being done in Delhi, the Principal Secretary of State of Gujarat was one of the audience of this. He in turn expressed his desire to bring this campaign for the first time in the state of Gujarat, where a homeopathic NGO got in touch with the central government and the state government as the other two partners of the triangle. So the public-private partnership got into its effect. The central agency, the Department of Ayush, contributed funds. The State Department of Health contributed with its manpower and already existing infrastructure so that replication and duplication doesn't occur. And the NGO that I represent came up with all the design and the delivery systems of that healthcare model. This incidentally entered into a MOU, where we entered into an MOU with the state government, which was signed by the Chief Minister of Gujarat, and effectively this model got operationalized. When operationalization of a model occurs, it gets basically into concept that is called as identifying objectives for which the association takes place. This was the primary association purpose, objectives, ANC visits of pregnant mothers, institutionalizing deliveries, maternal anemia, infant mortality rate, maternal mortality rate, immunization, and homeopathic orientation. The demographic field that was there existing prior to we entering, 3 ANC visits were attended by 51% of females, institutional deliveries were experienced by 40% of females, maternal anemia 10 grams was between 50 to 60%, IMR was 66, MMR was 253, immunization was taken care of by 50% of the children in the whole taluka. Grade 3 malnourishment was identified in 17 per 1000, and annual deliveries in that block was 3000. And orientation to homeopathy was just between 10 to 15%. That's where we began our association in this public-private partnership. We evolved a systematic model to this. What you see on this triangle on that side, the bottom of pyramid says that Ayush Swasthya Karyakarta, that ASK, 1 per village, multi-purpose workers, MPW, 1 per 5 ASKs, medical social worker, 1 per PHC, medical officer, 1 per PHC, and then there's a project officer. This was an operational model that was there. The other triangle talks of a monitoring committee. This whole process was monitored very, very carefully by the state government and the district health authorities as well. The process involved in operationalizing this model, a lot of training was undertaken, a lot of it. Medical officers were trained, but we undertook 35 sessions of training in 1 year. Medical social workers were trained. We undertook 22 training sessions with them in orienting them towards homeopathy, as well as community needs that homeopathic doctors need to understand. Multi-purpose workers, we undertook 66 training sessions, which almost amounts to nearly more than 5 per month. And Ayush Karyakartas who were there, we also undertook a training program of 66. The primary reason over there was to orient them to concepts of homeopathy and making them integrated into the whole concept of health system that India delivers. The 5 PHCs that we are just listing down, Choranda, Walan, Handod, Methi and Raro, these are the names of these 5 PHCs. The number of villages is listed in the next column. The last column talks of the distance from our base hospital. The distance carries significance over here because during a non-rainy season, this distance appears insignificant. But once rains slash this territory, it's very, very difficult even for a 2-kilometer travel. This exists even today in some state, in this state of Gujarat, in the taluka where we served. Incidentally, what we thought that we should not go ahead all alone in this. Therefore, there are government existing schemes called as Chiranjeevi Yojana, Bal Sakha Yojana, Mamta Divas and Janani Suraksha Yojana. These are various schemes that government of Gujarat has floated, which were actively brought into this whole project mechanism.
1 minute.
Yes, sir. The operational aspect had these different issues of health orientation and training that I was just describing to you about. The impact of all these things had to be monitored. The impact was monitored by the state and the district authorities very, very regularly, but the central authorities found it difficult to come and monitor these activities. The impact was very, very significant. Post-intervention, if you see the comment, the post component of ANCs grew to 70%, institutional delivery is 85%, maternal anemia came down to 20%, IMR to 31.5, MMR to 157 from 253, immunization was registered in 90% of the children born in that taluka, and homeopathic orientation we were able to convert into 100% in the 3 PHCs that we had actively concentrated on. Issues faced? Yes, obviously a number of issues get involved when you get into these kinds of partnership across the world. I presume primarily in terms of linking up with each other, secondarily in terms of funding, and thirdly saying that what I promised to deliver, I did not contribute at all. We also face that as a part of contribution from the government machinery. Whether these models are replicable? Yes, we did that in 3 states of India. I don't see any difficulty in replicating anywhere in the world. Database management systems is a very critical component in delivering of these kinds of projects. We are actively into it. We have a huge database on the data that we collected in these services. Creating mindsets of working in partnership. Yes, in homeopathic institutions, I think partnership is a very critical factor, and we should all collectively look into creating partnerships rather than going ahead all alone. Educating various agencies, yes, very, very critical and very, very important. I finally thank all these people whom you see in the photograph, the mother, the child, the driver, the doctor who went over there, the social worker, and ladies and gentlemen, Department of Ayush, Government of Gujarat, to make this experiment an experienced reality. Thank you very much.